Hello, everyone, and welcome to the Center for Optimizing Rural Health's monthly webinar. Our topic today is making corporate compliance practical and manageable in 2021, presented by Patty Harper. Thank you for joining us. I am Cassidy Avila, and I will be moderating the webinar today. Just a couple of notes before we jump in. Everyone is muted at this time, but Ms. Harper welcomes questions and encourages questions. So if you think of something and you want to unmute yourself and ask a question or type a question into the chat, we will either fit it into the presentation or we will hold it until the end. But either way, we will definitely make sure we get your question addressed. We are recording this presentation and we will make the slides available as well as a link to the recording available on the CORE website. And you will also be able to pull down the slides and the handouts. So it is now my pleasure to introduce our speaker, Patty Harper. Ms. Harper is CEO of Inquiseq LLC, a business and healthcare consulting company based in Louisiana. She has over 21 years of healthcare experience in the areas of healthcare finance and reimbursement, health information management, compliance, and practice management. She began her career as a hospital controller and reimbursement analyst. Patty holds a BS in Health Information Administration from Louisiana Tech University and holds numerous certifications in her field. Patty is a frequent speaker and contributor for national, state, and regional and rural healthcare associations on these and other reimbursement-related topics. She has held memberships regional, state, and national organizations throughout her healthcare career and currently serves on the board of the National Association of Rural Healthcare Clinics and the Louisiana Rural Healthcare Association. Welcome, Patty. We are so excited to hear your presentation today. It is all yours now.
Thank you, Cassidy. I'm so excited to be doing this for CORE. Thank you all for joining us today, and feel free to ask questions in the comment box, chat box, or to ask me if you want to. So, making corporate compliance practical and manageable in 2021, is that even possible? You know, you may be thinking that. And what I want to do is break down for us today a couple of simple ways to implement compliance. And so our discussion points are going to include what is regulatory compliance. So in my mind, there's a couple of different types of compliance. So we have regulatory compliance. We also have facility-specific compliance. So for rural health, that would include our critical access hospitals, our small PPS rural hospitals, rural health clinics, maybe even FQHCs. And then we're going to talk about what is a corporate compliance plan and what are the required elements of a corporate compliance plan. And we're going to talk about where do we go wrong with compliance? How do we make compliance more relevant and more practically practical to our organizations? So we're going to start out with just compliance. So compliance is just sticking to the guidelines and the rules, right? It's the regulations that are established by federal, state, and local laws. And so I usually do this presentation for rural health clinics. So for Medicare and Medicaid providers and for rural health clinics, we could also add critical access hospitals or any other rural healthcare facility. There is both general compliance as a Medicare Medicaid provider. There's general compliance as far as other federal laws. And then there is specific guidance as far as meeting the conditions of certification for our facility type. So basically just adhering to the rules. That's what compliance is. And we don't always like rules in our lives, but we know that healthcare is a regulated industry. And so we don't have to make this harder than it is because the framework for our compliance already exists. So much of it is already codified. It's in the Code of Federal Regulations. It's in our conditions of participation. It's in our conditions of certification. So we don't have to reinvent the wheel on what compliance is. We just have to know what it is. If we don't know what the particular details for our regulatory compliance are for our facility type, then we need to learn them, and then we need to teach them throughout our organization and create a culture of compliance. It can be very overwhelming. So where do you start if you're either having to revamp an old compliance plan? Where do you start if you are seeking certification or accreditation for a specific facility type, like a rural health clinic or a critical access hospital? Where do we start? Where do we even go for the information to have a baseline for compliance? So I am an information nerd. I actually like to go and find these things. But if you're not there, I still want you to know where you would look for them, where you would find this information. So we have lots of different kinds of compliance. We have compliance, of course, that comes to us from the Department of HHS. That includes CMS. It also includes the Office of Civil Rights, which also HIPAA falls under the Office of Civil Rights. We also have Office of Inspector General Enforcement. We're going to talk about OIG sanctions and that part of compliance a little bit later in the webinar. But as healthcare organizations, we also have to comply with, be in compliance with other federal laws, which include labor laws. Maybe they include OSHA laws to ensure our employee safety. We also typically have to be compliant with all of our state laws and regulations, and even our city and county level laws, as far as zoning, business permits, those types of things. So compliance has a big umbrella, and all of these things fall under compliance. And like I said, we're not going to reinvent the wheel. So I don't know how many of you have built a home recently. Maybe you've built a business. Maybe you've been involved with a new capital project at your hospital. But would you even get started without a blueprint? Would you even be able to hire a contractor if you didn't have a blueprint for that building? And obviously you would not. We have to have a blueprint, and we actually have a blueprint for healthcare compliance, for regulatory compliance, and that is the federal, state, and local regulations that we just discussed. So we have that blueprint. We don't have to guess. We don't have to wonder, what is CMS going to require of me? Where is the bar? What is my accreditor going to require of me? We have a blueprint. So most of our blueprints start in the Code of Federal Regulation. So we call that the CFR. I just have a couple of slides for you listing the sections of the federal code that deal with different types of healthcare programs. Everything that applies to us in healthcare is going to be found under Title 42. So it's always going to start with 42 if it has something to do with HHS. So our general guidelines for Medicare participation, for what is a benefit of Medicare, what is not a benefit of Medicare, how Medicare monitors program integrity for both the Medicare and the Medicaid programs. These are your go-to citations for those references. Hospital regulations are found also in that same Title 42. And so this is where we're going to find our conditions of participation for both inpatient and outpatient services. So we have that in the federal code. If we are a critical access hospital, we have a special section of the code that deals with critical access hospitals. Of course, in rural healthcare, we rely on critical access hospitals to be our safety net providers, as well as other providers, including our rural health clinics. The regulations for RHCs and FQHCs are combined in 42 CFR 491. The creation of the rural health program is found in 405. And if you have a rural health clinic or an FQHC that is provider-based to another entity, the provider-based statute is in 42 CFR 41365. Just want you to have those references, because remember, those are our blueprints for as we build our compliance program. The most up-to-date place to go to look up those references is in the ECFR. So the print Code of Federal Register is published annually. This link on the bottom of this slide to the ECFR is a real-time link. So this is where you're going to want to go to make sure that you're not just Googling and pulling up an old, out-of-date copy of that particular section of the code. You can browse through there. You can also enter those exact citations that are on the previous screens, and you can look up those codes. So this is where you want to go if you actually want to look up a federal regulation. Another place that we want to go for guidance is CMS has internet-only manuals. So these are not printed. They are only available electronically. There is an internet-only manual for every healthcare facility type. So this is where you will want to go if you want to get interpretive guidance or practical interpretation of the regulations. It's going to be in these internet-only manuals. So they are considered to be sub-regulatory, these manuals are. However, that's pretty much what surveyors will stick to and what administrative law judges will usually side on, side with the more layman's language included in these manuals. So we know where our blueprints are. And so part of our problem with healthcare is that we are reactive by nature. Just the very essence of what we do is to respond to people in need, to respond to emergencies. And so when it comes to compliance, with a lot of other things that we do, we're not as strategic and proactive as we really would like to be, because we find ourselves in a world where our hair is always on fire. And so the first thing that we have to do is change our mindset about compliance. And that's probably the hardest part of making this practical and manageable, making it relevant, is that we have to start thinking about it as something that we're doing to avoid pain. So typically our reaction is we don't want to deal with compliance until we get a survey citation, until we find out we're doing something wrong, until somebody files a complaint against us, and then we will react. We will make that plan of correction. We will fix that problem. And I love this quote by Aristotle: the aim of the wise is not to secure pleasure, but to avoid pain. So as much as we can do to be proactive, be strategic in creating a culture of compliance, the less reactive we're going to have to be, and the less compliance violations that we will see ourselves face. So one of the basic things that we want to do, particularly with facility-specific compliance, is we want to create policies and we want to maintain evidence documents that support the conditions of certification for our facility type. So if we are a critical access hospital, if we are a rural health clinic, we want to create policies as a backbone of our compliance plan. And we want to create those straight from the regulation. We only want as many policies as we have to have, and we want to make sure the policies that we have are ones that a surveyor would be looking for. And so written policies They need to meet our conditions of certification. They need to meet overall conditions of participation for Medicare and Medicaid and other payers. We also need a compliance plan to show that we are being proactive in preventing fraud, waste, and abuse. And then if our organization is accredited by Joint Commission, by DLV, by the compliance team for rural health clinics, their requirements may be above the regulatory compliance requirements. We'll need to know what those standards are. The biggest that we see when we're working with organizations on compliance is have too many policies. They have too policies, and their policies are too long and too detailed. So when we're writing policies, we want broad language that establishes compliance, make sure we're under that regulatory umbrella without locking into a written process or a procedure that might be dynamic. So we also want to organize our policies in a way that easy for us to retrieve. We also want to organize them in a way that we know which CMS survey tags or which accreditor standards those policies meet. So when we're asked to prove that we're in compliance with something, we know that our policy 200 is going to relate to JTAG 0044. So we just want to give ourselves those tools to make compliance easy. The other thing that we see often, particularly in smaller organizations like our rural healthcare facilities, our hospitals, and our clinics, is that people will try to use written policies to manage people instead of to ensure compliance. We don't want policies on where to park. We don't want policies on clocking in and out necessarily, or we don't want policies on what's going to happen if your tennis shoes are dirty or if your scrubs are wrinkled. So those are things that we can handle through our handbook, things that we can general employment policies for, general policies for, but we want to give our main backbone of our compliance to be broadly written policies that allow us operational flexibility. The way I like to think about it is that policies, they are the big banner that are over us that are broad statements of compliance. We are going to be compliant with all of the Office of Civil Rights requirements for treating patients and employees. So processes are going to down on that a little bit more. They are going to be more detailed guidance that give us clarity. They can be addendums to policies. They can be supplemental documents. And we're going to drill that down even more to standardize workflow and task having procedures. So our procedures can be in the form of a job aid. Our procedures can be part of role-specific training. We can reference those in our policy. Necessarily have to have all of our processes and all of our procedures hardwired into our basic policy of compliance. We're going to give ourselves more operational flexibility if we use other documents for specific deals. We also want your written policies. Now we're still talking about policies that are going to help you meet your conditions of certification or your overall compliance with participating in a Medicare, Medicaid program. We want them organized. We want them systematically organized. Like I said, we want them numbered in a way that makes sense. And we want them to have a standard format so that they're easy to read for both our employees, our staff, and for surveyors. And we want to make sure that we track effective dates and we have version control and are able to archive older policies. So this is a screenshot just as an illustration of a compliance platform that we use for our rural health clinics. So I just wanted to give you an example of how you could organize policies. You could do this organization in a number of ways. I know many of you have document management system that help you organize your policies. Here is an example of what a policy might look like. We want a very neat header. We want it to be easy to read. We want to know what type of policy is, how numbered. Like I said, we want a revision date on it, and then include the survey JTAGs from CMS along with CFR reference. That way, if someone wants to know, are you compliant with a certain aspect of certification, you have that easily there. You know, I don't know if you follow any of the forums or the listservs. People will always be asking if somebody will share a policy that they have on a particular topic. And then we go into an organization and we're looking at their policies, and they've downloaded that policy somebody shared with them, and they haven't completely customized it to what they do. Even still have liquid paper over the name of the clinic and written their name of their clinic or their hospital. So we make sure if we use other policies to help compile ours, we actually have those policies customized to our organization. In addition to having written policies for our facility, we also want to know which evidence documents we need to maintain in order to be able to evidence compliance with certain standards. And we also want to organize those in a way that they're easy to retrieve. We want to identify them. We also want to organize them. Proof of compliance is especially difficult during a survey. Evidence documents are not easy to find. So if we have a surveyor on site for any type of accreditation and we're scrambling, pulling file folders, administration, there's some information in the chief nursing officers in their files, some of it's in HR, and we're scrambling around, we're not going to look organized. And so we just want to make sure that we know what evidence we need and what the surveyor will want to look at. These are just some types of evidence documents when we're talking about going through a survey, what an accreditor or a state agency would look for. Licenses, certificates, report, fire inspections, public health inspections, maybe correspondence from Medicare contractor, correspondence agency. And they may also want to look at documents that support quality and risk management. And they may want to look at samples of notices that you have or disclosures. We are all required to disclose our ownership, and we're also supposed to have Office of Civil Rights notices posted. A surveyor might also look at proof of education or here's just an example, and this is just an example. Within our platform for rural health clinics, we have a place where we can load the ads right with the policy that it most directly correlates to. Evidence documents, you could common drive within your hospital information system. Just have them organized in a way that they can readily be retrieved and shared with stakeholders, including a surveyor. The other thing that really tricks us up with compliance, and we find ourselves trying to wrap up for a survey, that we have failed to keep evidence documents or those policies up to date. And so we really want, whoever we're managing that, to have a built-in team. Can be you have sometimes document management systems will have a built in tickler, but we just want to make sure that we are staying on top of everything and we're scramble to update everything all at one time. We found that most organizations, if you review 2 pieces of your survey evidence a week, then have touched everything that you need to at least once a year. So trying to say make it manageable, to be, oh my goodness, come up on survey and every be redone at the time. An example of a tickler list would be maybe something like this, where the expiration dates or the reminder dates are on a heat treated type calendar. So we know which items need the most attention, what is our priority. And it may be simple as just reminding us to review all our contracts, reminding us that we need a program evaluation, which is needed for RHC and critical access hospital. Maybe it's updating emergency preparedness, looking at our HIPAA risk assessment. All those things typically have to be done once a year. And here are some more examples of things that we want to make sure don't fall in the cracks. We don't want our medical director's license or our chief medical officer's license to lapse. It may have been renewed, but we may not have a current copy of it. We may not have those current inspections as evidence. We may not have performance evaluations or employee health files up to date. So anything that your policy says needs to be reviewed at a particular interval, or anything that your policies say that you need to retrain on at a specific interval, we need a system to remind us of those dates so that we always stay in compliance. We're not finding something and then having to catch up. We're staying on top of everything. So those were the things that I was going to talk about, facility specific compliance. One thing I think that's very helpful is to know that every healthcare organization, every provider type, from your one doc shop all the way to your major healthcare systems, everyone is required to have a corporate compliance plan. And there are 7 elements in that corporate compliance plan. So I thought it would be helpful if we would break those down today and look at those 7 elements of a corporate compliance plan. Now, it could be that your organization spent a lot of time and effort developing a corporate compliance plan maybe 20 years ago, and maybe that corporate compliance plan is up on a shelf somewhere and it's very dusty and nobody has looked at it and we don't even really know what's in it. Or maybe we developed HR planning, HR training based on that corporate compliance plan, and we need to update that or freshen it up. So I thought we would look at the 7 elements of a corporate compliance plan. The first one is that we have to have corporate compliance standards as an organization. That's probably the most important part of having a corporate compliance plan, is developing that and make sure that we have a system that is going to prevent fraud, waste, and abuse. We also have to have a written standard of conduct document. That standard of conduct document is part of our corporate compliance plan. Sometimes people will confuse the standard of conduct as being the complete plan, but the plan includes policies, processes, employee training, other written policies that we have that relate to compliance. That all makes our compliance plan up. But the written standard of conduct is something that a surveyor will want to see. So here's just an example of a very simple rural health clinic standard of conduct. It's basically going over with the employees through employee training what they need to know about corporate compliance. And so on the last page, there is a signature page that we'll want to make sure that evidences that employee has been trained. So some of your organizations may call this standards of ethic or ethical conduct. But we have to have something that we can use to both train our employees and also to evidence that we have done that training. A very important part of a corporate compliance plan is to make sure that as a healthcare organization, you don't hire anyone who has previously been excluded from the Medicare or Medicaid program. And so this is something every week someone will say to me, I knew nothing about this. Seasoned HR people within healthcare organizations will say, I'm hearing this for the first time. So I want you to be aware of this excluded party database, exclusion database. The link is at the top of the slide. Before you hire an employee, before you make a job offer to an employee, and it's all employees, it's not just physicians, it's not just licensed staff, it's all employees. We need to check and make sure that they have not been previously excluded from the Medicare or Medicaid program. And so it's a very simple database search. You're going to put the person's last name and first name in there. We want to make sure that for people, particularly women, that we are checking all of their possible names, maiden names, previously married names. So we're going to enter that name in this search box. We're going to search for that, and it's going to tell us if there is or is not a result for that name. If we have a very common name, like John Smith, then it's going to return to us all of the John Smiths. And then there is a second screen where you will enter your employee's Social Security number, and then you will get a second results screen, which will tell you if that Social Security number matches an excluded person or not. So we cannot offer a job to anybody without checking this OIG exclusion database. And like I said, they're very serious about this. And if you have hired someone, then you need to self-report that. And there is a penalty for having hired somebody without checking this list. The OIG suggests you check it before hire and at least annually. But since the Affordable Care Act was implemented, many Medicaid programs, including Texas, Louisiana, Oklahoma, I could just name a bunch of them, require you to check this list monthly. And it's possible that you can hire somebody and they're not on the list, and then there is some investigation in progress, and then they are on the list. So you want to continually check this periodically to make sure that none of your employees have been excluded. We had a medium-sized clinic that's very concerned about compliance that was checking this. They checked it 1 month. They didn't have any hits on it. They checked it the next month. They self-reported. It was a back office employee that had been excluded years ago under a different name. The clinic had to pay back 1.5 times of every Medicaid payment that they received. And so it's a very important thing to do. So we have a great question. How do you know if your state requires monthly versus yearly checks? That's a great question, Teresa. So on your state Medicaid, your state agency's Medicaid page, if you will search for excluded party, usually you will be able to find a statement about what their requirement is. Many states have their own database that is actually linked to the OIG database. So sometimes you can search straight from your state's page. If you're having trouble finding what your state requirement is, if you will email me, I'll be more than glad to help you locate that. Great question. Okay, We need to move right along here. So our second part of a formal corporate compliance plan is that we have to have a designated compliance professional. We typically call that person the compliance officer. It can be system-wide, it can be facility-wide, it can be specific to your particular type of healthcare organization. The thing that's important about a compliance officer, and the problem we have with rural, is that often our compliance officer is also someone else in our C-suite, right? And the person who is the compliance professional, that compliance officer, needs to be able to have both independence and an authority. They need to be able to report directly to the board when they suspect that there is a compliance issue. Often when in our small organizations where everybody wears a lot of hats, it can be, that individual can be reluctant to go straight to the board to report a problem because they may be implicating themselves in another one of their roles or their responsibilities when they do that. That individual person who's responsible for the compliance has to be the one responsible for maintaining and coordinating the compliance plan. So this can be a challenge in our smaller organizations. We also have to have open communication about compliance. So I talked early on about creating a culture of compliance. And I think this is really where we make it or break it, is that we know that we're supposed to have an open door policy. Some organizations don't like an open door policy. You know, they want a little bit more structured way to communicate concerns and issues. So we can have hotlines, we can have blind email communication, we can have complaint boxes placed around our facility. But we need to make sure that that culture of compliance communicates that we really are not going to retaliate against anybody that brings up an issue. So many times the person who brings up a complaint, they become the problem. And the whole purpose with the compliance plan is that we have a way to stay in compliance. So people should be able to ask questions. They should be able to question processes and ask for somebody to look into something. So open communication is very important as the third part of our compliance plan. Education and training is very big as part of our corporate compliance plan. It does no good to have that big corporate compliance plan up on the shelf and nobody really knows how to put feet to it. And so we want to make sure that we're training on fraud, waste, and abuse of the Medicare program. We're talking about quality of care, that we're making our written policies and procedures available to our staff, and that roles and responsibilities are clearly defined so that everybody knows what it takes to have a compliant organization. One of the things that we tend to do is we put substance over form. No, I think I have that backwards, don't I? We put form over substance. So we have things that we want people to sign when we hire them, but we don't really train on them. What we really need to do is create buy-in by engaging the staff and making compliance relevant to their daily job. The areas of compliance for somebody in billing and coding is different than somebody who's in direct patient care or someone who is responsible for maintaining our physical plant. So we need to make compliance relevant to those employees, to their particular job functions. And we need to obtain feedback from staff. And of course, we always have to document the training that we've done. Our fifth part of a corporate compliance plan is that we have to be able to evidence that we can respond promptly to any concerns or issues of noncompliance. So this means that we take all concerns seriously. Often we'll have that one person who's always asking a question, always raising a concern, and somehow we tend to say, "Oh, it's just Julie again." Julie's bringing up another issue. She's splitting hairs. But we really need to be able to take all concerns seriously, and we need to have a process for investigation of any concerns. And then we have to know when there is an issue that we can handle internally and when there is something that we need external help in either investigating or in resolving. So we need to be able to promptly resolve any issues or questions that are raised. Part of that includes having monitoring and auditing processes in place. So we tend to use those words interchangeably. Monitoring is actually internal processes and auditing is an external process. So if you think about your financial auditors come in once a year, they're external third parties, but maybe your quality chart audits are an internal process, then that's a monitoring function. But whatever we call it, we need to be able to prove as part of our corporate compliance plan that we're watching what we're doing. We're keeping our thumb on it, and we're making sure that our policies and our processes are being followed. Some different types of monitoring and auditing can include coding and billing reviews, different functions within our revenue cycle to make sure we have proper checks and balances. Another problem we have within our critical access hospitals and our smaller organizations is that we don't have very many people. So we don't have the appropriate separation of duties, those segregation of functions that allow the correct independence. And then we also want to be looking at our service contracts, making sure we don't have anything that is a Stark requirement, a Stark law violation. For rural health clinics and rural health organizations, our Stark laws have been lessened when it comes to referral requirements. And then, of course, we can always want to be monitoring standard of care and how our medical staff is functioning within our organization. The last component of our corporate compliance plan is that we have to have a written, already established policy on how we will discipline people who are determined to be uncompliant. And so we need consistency in how we apply those. And we need to retrain people when there's an issue that comes up. So not everything that comes up is going to require an employee to be terminated. Often we just need to retrain, and then we need to monitor to make sure that that training is effective, that ongoing performance improvement that we do in other areas of our hospital. If we do discover through an investigation that we do have a serious issue, we are required to self-report to the Office of Inspector General to remedy whatever it is that we have done that is not appropriate. So just in going back over the 7 elements, I'm just listed them here on the slide for you. And then I think the other important thing is keeping compliance relevant. So it's not a very sexy topic, regulatory compliance. There are other people within our organization that are always giving presentations on transformative culture and really fun, exciting, visionary things. And compliance just isn't that way. So we need to really work to keep it relevant and keep people interested in it. And so the main ways that we go wrong is that we fail to create that culture of compliance. We say we want to be compliant, but we don't really create a culture, that open door policy. And then we've reduced compliance to an HR checklist. And like I said before, we have form over substance. So on paper, it looks like we're complying, but we really haven't gotten through to everybody and explained to them how compliance relates to their job. We make policies too complicated and difficult to follow. No one is going to read a 47-page infection control policy, so there's no way they're going to be compliant with it. So you may want to break policies down into department policies, where infection control applies to surgery, then infection control applies to the floor, maybe it applies to clinics, but a big gigantic policy is not going to be read, it's not going to be followed. And then often we distance the compliance function from our daily operations. Either that compliance officer is within our overall system, and we just, again, have failed to bring that culture of compliance down to where everybody lives and works every day. We don't stay current with regulations. That's a big problem with where we go wrong. There have been several changes in emergency preparedness. There is a new Appendix Z out for all facility types, which is a very recent change. So that would require us changing written policies based on an update in regulations. And then sometimes we just assume that everybody knows what they're supposed to do. And so we don't really talk about compliance. So I think those are the main ways that we go wrong. Our compliance needs to be static and dynamic. And what I mean by that is our overall blueprint, those written policies and procedures, for the most part, need to stay static. They don't change often, but maybe the way that we operationalize that compliance, we have some flexibility for that to be more dynamic. So we want to keep our training methods fresh. We want to change the way we're monitoring things. You know, we don't want to set something in motion and then never see if it's really being effective. And then we want to make sure, particularly with compliance, that we balance responsibility and authority. We don't want to give people the responsibility for compliance in their area if they don't have a comparable amount of authority to lead and manage people over that compliance area. Purposeful. I love this quote too. To be relevant, you need to be purposeful. And I feel like life is so busy right now. We really have a hard time making things purposeful. But we really don't need to wait until we have a survey deficiency or wait until we have the results of a payer audit to reveal a gap in compliance. We really want to make sure we're on top of our game. And so we need to revise things and simplify them. As much about our compliance program that can be dynamic in the way we operationalize it, that's going to be key to making it relevant to our employees and to our staff. And so we don't need to assume that those written policies or that written compliance plan that's up on your shelf, that is still up to date or complete. And we find within bigger healthcare systems that have critical access hospitals and rural health clinics and FQHCs, that their corporate level policies may fail to meet the facility specific compliance required for that type of healthcare facility. So don't assume that your corporate level policies are meeting you where they need to be day to day in your rural health operations. Monitoring changes. Since we've been in COVID, we're not having live conferences. We're starting to see live conferences come back. It's very important to be connected through newsletters, announcements, news feeds, organizations like CORE that makes resources available for you. Organize that so it's not all coming into your inbox. Maybe you want to set up email folders, and once a week, you'll look at those updates. You want to network with other people outside your organization. Attend state, local, regional meetings, Zoom webinars like this one. Join professional associations. Everything you can do. We all have so much going on. It's terribly difficult to stay up on monitoring changes in regulations. We will most certainly see some changes in regulation come from the new presidential administration. That always happens. We have changes in the cabinet secretaries, changes within the agencies. So healthcare certainly will see some changes. We are expecting changes to come even this week on knowing if the sequestration amount is going to continue to be suppressed, and also on our RHC grandfathering rules. So use the resources available to you to help you monitor all of this. Here are some basic compliance resource manuals. The OIG has sample compliance plans for every facility type. So if you don't know where to get started, you can search here. There's also a great video that goes over these same 7 steps that CMS has out there, compliance plans for a small healthcare organization. I did not put that link on here, but that's a great link as well. Our organization also has a corporate compliance plan template that is very simple and streamlined that I would also be glad to share with you. No strings attached. You'll just get what you ask for. No, you won't get on our sales list or anything, but anything that I can help you find in that resource area. So Cassidy, it looks like we're a few minutes early. We have time to take some questions. Okay. I don't see any questions in the chat box.
I don't have any in mind either. I did get a private chat asking if the slides would be made available, and yes, they will be made available. And Ms. Harper is also sharing with us a handout as well as the recording to this presentation. So you guys will get all of that in an email following today's session.
Okay, great. You're also going to get my email address and my cell phone number. So we always answer questions anytime that we've done a webinar like this, because we know sometimes that your questions may bubble up to the top in a day or two after you've had a chance to think about it or talk about it within your organization. So if you have a follow-up question, feel free to email me, reference this webinar, and I'll try to get you the information that you need. Again, I promise you won't be placed on any solicitation list or anything like that.
Sherry says to you, good presentation, which I will
Okay.
agree. That was excellent. Thank you for saying that, Sherry.
Oh yeah, we appreciate that. So again, so you can email me, you can call me if you want a sample of our compliance plan template or any other information that you think that that I could help you find. If you need help finding that your state Medicaid's requirement for the excluded party checks, be glad to help you with that. Great to be with you today, and I appreciate the opportunity. This is my first core webinar, so so great. Okay, I see we're putting that link out there. That's perfect.
Patty, I went ahead and that link, you guys, is to a survey that just lets us know what other topics you might be interested in hearing a webinar on. So we always like to throw that out there in case there's a topic that you really feel there is a need for and that need is not met. We would love to be able to have that opportunity to meet that need. So I went ahead and included that link. Thank you, Jenny, for your comment as well. And as Patty said, this was her first core webinar, and we were so pleased with it. And we were so pleased with you guys being able to join us today. I don't see any other questions coming through, and we're getting close to 1 o'clock. So if nothing else comes through, we will go ahead and adjourn. But as Patty said, please feel free to send her or even myself your questions, and we will make sure that they get addressed. So be looking for that email, which includes the recording, the slides, and the handout. And we wish you all a wonderful afternoon. Thank you so much, Patty. It's been a pleasure.
Oh, my pleasure too. Thank you so much. Everybody have a great afternoon.
Bye, everyone.